All right, let's kick things off with some basics. You know, when we talk about pathophysiology, it's not just about big fancy words. It's about understanding the nuts and bolts of what happens in the body when something goes wrong. So, let's start easy. Acute versus chronic conditions. These terms? Super important. Everyone. Acute. Think sudden. Like a sprained ankle or, I don't know, strep throat. Short-lived but intense. Yeah? Now, chronic.
Is the complete opposite, right? We're looking at conditions that stick around for the long haul, like diabetes or heart failure. They're life-altering conditions that demand long-term management. And here's where this gets interesting. The body doesn't just give up. It adapts in both acute and chronic situations. That's where terms like atrophy, hypertrophy, and dysplasia come into play.
Exactly. Atrophy, for example, is when cells shrink because they're not being used. Imagine being immobilized after surgery. Those muscles, they lose size fast. But then there's hypertrophy, where cells actually get larger to meet increased demands. Like think of a heart under stress. It's working overtime due to something like hypertension. It literally grows bigger.
But here's the kicker. It's not always healthy, right? That same heart that's growing might start struggling because it's overworking, which leads to problems down the line. And dysplasia? That's when cells start growing in abnormal ways. It's often a warning sign, like what you might see in the respiratory tract of a chronic smoker.
And that's the perfect segue, Ethan. Because, okay, let's move into inflammation. Oh, this one's fascinating. Now, acute inflammation, it's like your body's first responder rushing to the scene of an injury. Redness, swelling, pain. It's the works. Classic example, twisting your ankle. It hurts, it swells. Your body's like, hey, let's fix this fast.
But chronic inflammation, on the other hand, is much sneakier. Think about something like obesity-related metabolic syndrome. The inflammation isn't as obvious, but it's ongoing, almost smouldering, and can lead to conditions like type 2 diabetes or cardiovascular disease. For nurses, understanding these processes helps us predict complications and tailor care protocols effectively.
Oh, totally. And it makes such a difference, okay? Here's a quick case study. Imagine a pediatric patient comes in with a swollen knee and a fever. Now, the nurse spots these signs early. Boom, rapid intervention kicks in. Turned out it was septic arthritis. Caught just in time, and the kid recovered perfectly. That's how knowing this stuff can literally save lives.
It truly does. Recognizing those early signs of inflammation is key, as they guide both diagnosis and treatment. It's a great example of why we, as healthcare professionals, need to stay alert and informed, because timely intervention doesn't just treat, it transforms outcomes.
And that's why this is so crucial. Let's arm ourselves with the knowledge, yeah? All right, folks, as we've talked about recognizing and addressing key health conditions, let's shift gears and dive into pharmacology. When we talk about medication, 3 words should always be top of mind: effectiveness, safety, and
selectivity. Right, these are the pillars of good pharmacological practice. Simply put, effectiveness is about, well, whether the drug actually works.
Exactly. Like imagine you've got the worst headache, right? You'd expect that pain reliever to actually relieve the pain. Otherwise, what's the point?
And safety, it's critical. Nurses need to understand which medications are safe, even in high doses. But here's the catch. No drug is completely free of risks. Paracetamol, for instance, is considered safe in regular doses, but take too much, and you're dealing with serious liver toxicity.
Oh, and let's not forget selectivity. The ideal drug should only affect the thing it's meant to target, okay? But in the real world, we get side effects because drugs aren't quite that picky.
That's right. Take beta agonists, for example, used in asthma to relax airway muscles. They're great at opening up the lungs, but in some patients, they might also cause a bit of a racing heart. It's all part of the balance between benefit and risk.
Speaking of risks, adverse drug reactions. This is where we need to be super vigilant. Remember thalidomide? Designed to treat morning sickness back in the 50s and 60s, but it led to those devastating birth defects. That case revolutionized drug safety protocols.
And it's why we now have such rigorous testing and regulatory frameworks in place. As nurses, part of our role is spotting adverse reactions early, whether it's something mild like a rash or something life-threatening like anaphylaxis. It's our responsibility to act quickly.
Quickly and effectively. And hey, here's an important point. Patients trust us to catch this stuff. Like you said, even mild side effects can snowball if they're ignored. That awareness makes all the difference.
It absolutely does. And understanding the balance between those principles, effectiveness, safety, and selectivity, helps us make better clinical decisions. It's not just about prescribing a medication, it's about seeing these bigger picture.
Right? Knowing the why behind the what. But man, it's not always straightforward, is it?
No, it's not. But that's what makes this work so rewarding. Each situation is different, and staying informed empowers us to provide better care.
So true. And all right, let's pause there for a sec, because this all ties beautifully into what we'll talk about next. How medications actually move through the body. The processes of absorption, distribution, metabolism, elimination. You're going to love it. All right, let's pick up right where we left off. We're about to unpack how medications travel through the body. This is pharmacokinetics in action. Absorption, distribution, metabolism, elimination. It's the full journey, and it all starts with absorption. That's how a drug makes its way into the bloodstream. And trust me, this part sets the stage for everything else. Ethan, care to kick us off?
Of course. Absorption can vary due to factors like how the drug is formulated. For example, liquids tend to absorb faster than tablets. And then there's the absorption site. Take sublingual medications, for instance. They bypass the digestive system entirely, which can make them very effective for quick relief situations. But for older adults or even newborns...
Ah, yes. The differences based on age. Let's not forget that in neonates, their systems are still immature, right? And with older adults, slowed absorption because of decreased blood flow or stomach acid levels totally changes how medications work.
Exactly. And after absorption, we move to distribution. This is all about how drugs spread through the body. Blood flow plays a key role here. For instance, tissues with low blood flow, like bone or fat, take longer to receive the drug. And this is where older adults face challenges, with decreased total body water and increased fat content.
Meaning fat-soluble drugs stick around longer, right? They build up in fatty tissue. And let's not even get started on protein binding. Wait, actually, let's do. A drug like warfarin that binds tightly to albumin. If there's less albumin, like we often see in older adults, more of the drug stays free in the bloodstream. And boom, higher risk of bleeding.
Spot on. And then there's metabolism, primarily in the liver. With aging, liver function decreases, slowing the breakdown of drugs. This means drugs that are heavily reliant on first-pass metabolism, like propranolol, can reach higher plasma levels in older patients, posing risks like low blood pressure or dizziness.
Oh, and prodrugs. You know, drugs that only turn active after being metabolized. For those with impaired liver function, this process is disrupted, and suddenly that drug isn't working as intended. It's such a balancing act.
It truly is. And that brings us to elimination, the final stage. The kidneys handle most of this, but renal function naturally declines with age. Take creatinine clearance, something every nurse should consider before administering medications like aminoglycosides. It's just so critical in preventing toxicity.
And with kids, it's a whole other story. Their kidneys are still maturing, so excretion is slow. Dose adjustments, non-negotiable. Here's a quick clinical twist. Think about an older gentleman prescribed digoxin. Poor renal clearance leads to drug buildup. But thanks to careful monitoring and dose reduction, we sidestepped toxicity. That's pharmacokinetics in action.
Perfect example. And now we layer in pharmacodynamics, how drugs interact with receptors in the body. Let's take insulin. It binds to specific receptors on cell surfaces, facilitating glucose uptake. This interaction highlights how receptor activity drives therapeutic effects.
Yes, but here's the catch. Those receptors can become less responsive over time, like in type 2 diabetes, where cells become resistant to insulin. Makes you think, doesn't it?
Absolutely. And while pharmacodynamics emphasizes drug action, it also helps us understand adverse effects. Antagonist drugs, for instance, bind to receptors to block a response. A great example is naloxone, which is life-saving in opioid overdoses by displacing opioids from their receptors.
Such an amazing application. Pharmacokinetics and pharmacodynamics, they're really two sides of the same coin. And the takeaway here is personalizing care. No patient's the same, and understanding these principles, that's what makes nursing such a powerful profession.
Couldn't agree more. It's about blending science and compassion. And that's all we have for today. Stay curious, stay informed, and most importantly, stay inspired.
Yes, keep that fire burning, everyone. Until next time.